even if we can't figure out or pinpoint the exact reason why you're not getting pregnant, we have excellent fertility treatments and we have lots of options and things that we can do going forward to still help you get to that ultimate goal, to still get that baby in your arms. And even if we don't know the exact reason, fertility treatments, modifying lifestyle factors is still an extremely effective way to get to where you want to go.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as Our Baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Welcome back to another episode of My Fertility Podcast. In this episode, we're going to tackle a confusing and frustrating topic, and that is unexplained infertility. We're going to go over the definition, we're going to go over other factors that may contribute to infertility, and different treatment options, of course, giving you a good review of the evidence. We're hoping that at the end of the episode, you will feel that you have a good understanding of what it is, how we think about it as fertility specialists, what kind of factors lead to that, and what treatment options are available for you. When we're talking about unexplained infertility, or I think rather whenever we're ever talking about diagnosis in the world of infertility, it's just different. I think in other areas of medicine, there are clear medical conditions and there's clear diagnostic tests, and it feels a lot more black and white. When we are thinking about unexplained infertility, like what does that mean? If we go back to the textbooks and the guidelines, it basically means that there is absence of a definable cause for a couple's failure to achieve pregnancy after 12 months of attempting to conceive. This means nothing special, nothing fancy, no tracking, no ovulation predictor kits, just regular, unprotected intercourse. In terms of the testing, we expect to see a normal semen analysis and at least one open fallopian tube, or maybe two. Now, this depends on who is rating the definition and to what source you're using. A normal uterine cavity, meaning no polyps or fibroids or scar tissue in there, and regular ovulation. We did a whole episode, and that was episode 2 of our podcast, talking about the menstrual cycle. But just a quick recap. The ESHRE guideline for unexplained infertility said that regular ovulation means that the cycle is between 24 and 38 days, with the shortest to the longest cycle variation less than 7 to 9 days, and a menses or a menstrual period up to 8 days in length. The incidence is about 10 to 30% in the population, according to Spearoff, which is the textbook Bible of fertility for fertility specialists. But realistically, most people would agree that unexplained infertility happens in more like 30 to 50% of cases. Now, like Dr. Weiss mentioned, the pure definition would be open fallopian tubes, 1 or 2, regular cycles, normal uterine cavity, and normal sperm. Now, there's a lot of other factors that can play into that. For example, let's say somebody has all of these criteria, but they might have medical issues like poorly controlled diabetes. Let's say they have other conditions like an increased BMI. Let's say there is endometriosis. Let's say that the age of the egg is an issue. Let's say somebody is 41 or 42 years of age. So technically, if you're a purist, you would say people with these conditions still have quote unquote unexplained infertility. But as fertility specialists, we understand that these factors can be very significant in some cases in your ability to conceive. And then we would want to address those factors and treat patients with quote-unquote unexplained infertility that have those factors a little bit differently than somebody that has unexplained infertility without any of those other factors that can also have an impact on pregnancy rates. And that's why, as with everything in the world of fertility, we always start by thinking about individualizing to the patient that is sitting in front of us. That's where sometimes I know myself, I might shy away from giving a
clear-cut diagnosis to patients because it's rarely ever that. It's occasionally that simple, but very rare actually, where it's one thing where you can feel confident about it. The other thing also is there's lots of things that we can't test for. That brings me to, why do couples have unexplained infertility? One potential theory or one potential way to think about things is that there is a specific abnormality. There is something that is preventing a pregnancy from occurring, but we just can't identify it with our current tests. So, for instance, you can have a normal semen analysis, but when you actually get an egg and sperm together, fertilization does not happen. So, a fertilization failure. We also don't have tests specifically looking for the implantation potential in the uterus. We know that the uterus can structurally look normal on ultrasound or sono, but that doesn't necessarily mean all good embryos are going to stick. You can have implantation failure. Or there can be issues in terms of blastocyst development and the growth of those embryos, where you can have embryonic failure or blast development failure, potentially egg quality issues. And so these are things that we can't identify in this initial work of this initial testing, but they could be existing even in the background of unexplained infertility or other types of infertility that may not come out until later in the fertility journey.
Another reason why couples might have unexplained is that there is actually no abnormality. They're just at the lower end of normal fertility. So when we look at fecundity, which is a pregnancy rate per cycle, there is going to be a curve. We know that fecundity is higher in the first few cycles that you're trying, but there's always going to be couples at the tail end of that curve that everything is normal and they eventually do conceive on their own, but it just takes longer than normal. So when I see somebody, for example, that has been trying for, let's say, 13 months, that's what I'm thinking that could be. Somebody has, everything is normal, but they just have a delay to fertility. When we see somebody that has been trying for 5 years, then we start to think, okay, that's probably too far off the curve, and there is something that is likely at play.
Before we talk about what is concerning, it's important to talk about what is expected. So what is the, let's say, untreated or natural pregnancy rate per month? Natural cycle conception rate will decline as the number of failed attempts at conception increase. In younger couples, let's say where the person with eggs is aged 27 to 34, the pregnancy rate or chance of pregnancy may be even up to 30% for the first 2 months of trying, but it will decline to 8% after 6 months and drop further to 4% after 9 to 12 months.
In patients with unexplained infertility, cycle fecundability, it's about 2 to 4% per month after a year of trying to conceive, which is similar to couples that have actual fertility-related issues like oligospermia. And it also, of course, varies with the age of the female partner and the duration of infertility.
When we're thinking that it could be unexplained infertility, what do we do? How do we treat it? This is often a very difficult concept as well, because how do you treat something when you don't know what the problem is? The cause is unknown, therefore all treatments that we use for patients with unexplained infertility is empiric, meaning that it's based on experience, i.e. we're not specifically fixing the thing that we know isn't working because we don't know what that thing is. Any fertility treatment is a bit of a numbers game. Whether you're doing intercourse, IUI, or IVF, if there are more eggs that are in play in that cycle, you're more likely to get a quote-unquote good egg. If there's more sperm that are able to access that egg or eggs, it's more likely that fertilization will succeed and you'll go on to the next step of the pregnancy cascade, let's call it. So really part of the better pregnancy rates with IVF, for instance, will come from working with more eggs, let's say 10 to 15, as opposed to quote unquote regular intercourse, where we get one egg the vast majority of the time. So even if we aren't fixing this specific issue, the fact that we are giving more eggs, more sperm a chance or the opportunity, that in and of itself will lead to higher pregnancy rates.
Before we talk about fertility treatments, I think it bears mention again talking about lifestyle factors. I am going to keep talking about lifestyle factors until I'm blue in the face and you get sick of me talking about it, but it really is very important. By lifestyle factors, we're talking about a healthy diet, exercise, body weight, avoiding toxins, taking proper vitamins and supplements. And we actually went into all of these for both male and females in episode 6 and 7. So check that out.
And in fact, this is supported by the guidelines. ESHRI, or the European Society for Human Reproduction and Endocrinology, in their guideline in 2023 on unexplained infertility, first line recommends healthy diet and regular exercise. What's interesting is that things like, for instance, adjunct oral antioxidant therapy for men and women undergoing fertility treatments is, quote, probably not recommended, end quote. Probably because there's just a lack of evidence in terms of improvement in pregnancy rates. Acupuncture as well, quote, probably not recommended, end quote. And inositol supplementation is also, quote, probably not recommended, end quote. We'll talk about inositol here for a sec. This guideline is specifically looking at couples with unexplained infertility. For patients with PCOS, they don't have unexplained infertility. And so inositol is recommended for that patient population. We talk about that in episode 16 when we talked about PCOS. One key learning point in general is to remember that something that is good for a specific group is not necessarily good for everyone. So just because coenzyme Q10 or antioxidant therapy or inositol or acupuncture may not be good for this specific patient population doesn't mean that that holds true for everyone.
And also, lifestyle factors is not something that you do instead of. Nobody's saying go and eat healthy and get pregnant. Of course, we're still going to offer you fertility treatment if it's appropriate for you. But what we want to do is we want to stack things in your favor. Lifestyle factors can improve the chances of getting pregnant, even if fertility treatments are still necessary. And we actually go into a lot of details on that on our episode.
All right, so let's go through fertility treatment options, and we're going to talk about their relation to unexplained infertility. We're going to start from, I'm going to call it least intensive to most intensive. First up, we have ovarian stimulation of the ovary combined with intercourse. So this could be using something like Clomid or Letrozole and then helping couples time intercourse. There are guidelines from 2013, which were updated in 2017 by the National Institute for Health and Care Excellence coming out of England. And I mean, I just have to read the quote out because it speaks for itself. So in these guidelines, they say, quote, do not offer oral ovarian stimulation agents, such as Clomid, anastrozole, or letrozole, to women with unexplained infertility, end quote. There's a CFAS guideline, which is the Canadian Fertility and Andrology Society in 2019 about unexplained infertility, and it basically says the same message. The reason is that it has been found that doing this, letrozole with timing of intercourse, does not increase chances of pregnancy or live birth in the unexplained infertility patient population.
That's great that you mentioned that guideline because patients ask about that all the time. They always hear about, my friend had Clomid or Letrozole and they got pregnant. And sometimes I agree with the guideline, sometimes I don't, but definitely I agree with this one because if we know that it's truly unexplained, which means you're already ovulating, you're having sex, the tubes are open, then giving an oral agent and getting you to have sex, it's not going to make any difference. You're already ovulating. The oral agent is just making ovulate. And then timing intercourse, you've already probably been doing that for the last year before you came to see me. So it makes sense that it doesn't increase live birth rate. It can actually be damaging if it's going to lead to time wasted, which is really important when it comes to fertility.
You also bring up a good point. I think it's worth stating again. Just because something worked for somebody else or something worked for your friend does not mean that it's going to work for you because everybody has such different reasons to be in a fertility clinic or to have infertility. And that's where we really do personalize the treatment.
And actually, you're going to see in PCOS episode 16 and 21 that oral agents with time intercourse is actually very effective in polycystic ovarian syndrome. Again, polycystic ovarian syndrome, it's not the same as unexplained infertility. So it's two completely different diagnoses, two completely different mechanisms for infertility. So what can work in one type of diagnosis does not work in another type of diagnosis. So now let's talk about intrauterine insemination or IUI. We did cover IUI in episode 17. In terms of IUI, there are 3 ways of doing IUI. One is with natural ovulation. Another one is with ovulation induction agents that are oral, like clomiphene or letrozole. And another one is with gonadotropin medications. For unexplained infertility, there was a review in 2006 about natural cycle IUIs. This means do not take any medication at all, just wait for natural ovulation and do the IUI procedure at the time of natural ovulation. These reviews concluded that natural cycle IUI may improve pregnancy rates minimally, but it wasn't very clinically significant. The CFAS guidelines, which is the Canadian Fertility and Andrology Society of 2019, actually state that natural cycles IUI should not be offered to couples with unexplained infertility, as it is no benefit.
As Dr. Garcia mentioned, the next kind of layer to think about when we're thinking about IUI is adding in oral agents to stimulate the ovary with the goal of making more than one follicle at a time, and then layering that on top of IUI. In the literature around unexplained infertility, there's actually a lot more studies that talked about Clomid or clomiphene citrate. Again, it's not something that we use in Canada nowadays because it's no longer available. We use a lot more letrozole, but there are more studies that talk about Clomid. When we think about Clomid and IUI, there was a study called Guzik et al. That was published in 1998. And this was a review study of 8 other studies that looked at 932 treatment cycles. They found that the pregnancy rate per month using just Clomid and in reports was about 5.6%. And that if you added IUI into the mix on top of the Clomid, that pregnancy rate went up to about 8.3%. There was something called the FAST trial in 2010. In this study, they had 2 groups. The first group did 3 cycles of Clomid with IUI and then up to 6 cycles of IVF. The other group did 3 cycles of Clomid IUI. Then they did 3 cycles of gonadotropin, so these injectable medications with IUI, and then up to 6 cycles of IVF. There was a lot of really great data that came out of this study and this trial. And they found that in the first group, where they did Clomid IUI, then IVF, the time to pregnancy was about 8 months. In the second group, where they did Clomid IUI, then gonadotropin, IUI, then IVF, the time to pregnancy was now 11 months. Also, when they looked at their Clomid IUI group, they found that the pregnancy rate was a little bit higher, and it was about 7.6% per cycle. The gonadotropin IUI pregnancy rate was about 9.8% per cycle, and the IVF pregnancy rate about 30.7% per cycle. So from this, we can conclude that Clomid IUI does improve pregnancy rates and that it is statistically significant, but it's not a huge improvement in the actual numbers. It's a modest improvement. And that's Clomid IUI, and we do a lot more letrozole IUI nowadays. There was a study by Diamond et al. In 2015 where they had 900 women and they randomly assigned them to using Clomid, letrozole, or gonadotropin with IUI. The live birth rate with letrozole versus Clomid was statistically not significant, meaning it was considered to be basically the same. And that live birth rate was about 19% for letrozole and 23% in the Clomid group. Now, the live birth rate for gonadotropin was actually a lot higher, it was 32%. But gonadotropins also had the highest multiples rate, meaning twins, triplets, or higher order multiples. And the multiples rate was 13% versus 1% and 4% in the letrozole and Clomid groups. This is a very common theme that we see, that once you start using injectable medications with gonadotropins, that pregnancy rate might be a little bit higher, but the multiple rate is higher as well. There was another study by Farquhar et al. In 2017 where they had 201 women and they were randomized to 3 cycles of IUI with some sort of oral ovarian stimulation medication. It varied by clinic. Or they did 3 cycles of just having intercourse without any medications. From this study, they found 31 live births from the IUI group. And in the expectant group, or in the group that did not have active treatment, they had 9 live births. Now, what's really interesting, though, is that in that expectant group, one of these people actually got pregnant from IVF, which was totally not going with the rules of the study. And one of the people was also pregnant at the time the study started because they had done an IUI with ovarian stimulation. So really, it was actually more like 7 pregnancies. So from this, we can conclude that the chance of getting pregnant by IUI is over 3 times higher than it is by doing no active treatment. In summary, the CFAS guideline, the 2019 guideline on unexplained infertility, they say that IUI with oral medications is an appropriate treatment because it is more effective than expectant management, and that you can use letrozole or Clomid. The ESHRI guideline, the European guideline, again, strongly recommends IUI with ovarian stimulation as first-line treatment.
Another option for doing IUI in unexplained infertility is the use of gonadotropins. Gonadotropins are the injections that we use to stimulate the ovaries when we're doing IUI or IVF. The difference between using gonadotropins in IUI and IVF is that in IVF, it's okay to have loss of eggs, 10, 15, as a matter of fact, that's what we want because we are retrieving those eggs out of the body and fertilize them in vitro, and then we're controlling how many embryos are going back into the uterus. When you're using gonadotropin for IUI, you really don't want to have 15 eggs or 10 eggs because the risk of having a high order multiple pregnancy is very high, and that is a very serious complication of pregnancy. Gonadotropins used in IUI is limited because of the higher risk of having multiple follicles that will lead to cycle cancellation and a lot of tears and a lot of frustration for patients and doctors. Another issue with gonadotropins IUI is the much higher cost of treatment. And if you're going to get 2 eggs from letrozole that costs $20 and get 2 eggs from gonadotropin IUI that is going to cost $1,000, then it makes more sense to use the medication that has a lower cost. Now, gonadotropin IUI sometimes is used in people where we know those ovaries don't respond to the oral medication, or when we know that the ovarian reserve is so poor that even if we use gonadotropins, we're not at risk of developing 3, 4, 5 follicles because there is poor ovarian reserve and the ovaries just don't make that many follicles. So this would be a situation where doing gonadotropins IUI would be an option if we're trying something different from the oral medications. Generally speaking, people that have good ovarian reserve and unexplained infertility, I wouldn't use gonadotropins IUI because of the increased risk of multiples, the limited benefit according to the evidence, and the increased cost of the treatment. Like, for example, the FAST trial that Dr. Weiss mentioned was comparing couples that use clomiphene citrate and IUI and couples that use gonadotropin and IUI. And the difference in pregnancy rate was 7.6% for clomid and IUI versus 9.8% with gonadotropin and IUI. So looking at a review of this study plus other studies that were done in a meta-analysis, there is no evidence that conclude one is better than the other. And again, there is a risk of multiple births and the increased cost of treatments.
At this point, I think it's important to bring up one of the NICE guidelines as published in 2013 and in a statement that was made there. Here is my disclaimer. When I say this, please do not shoot the messenger. In this guideline, it says, quote, do not routinely offer intrauterine insemination, either with or without ovarian stimulation. Exceptional circumstances include, for example, when people have social, cultural, or religious objections to IVF, end quote. So from these guidelines, what we conclude is that there's not a lot of value in offering IUI to patients with unexplained infertility, either with or without the stimulation medications, that you're not really getting a significant increase in pregnancy rates. Now, I certainly do not practice this way. And we know that the CFAS, or Canadian Fertility and Andrology Society, and the ASRM, which is the American Society for Reproductive Medicine, that their guidelines do recommend the use of IUI. And so this is where a controversy does lie. But what I thought was really interesting is that this guideline came out in the UK in 2013. In 2015, they did a survey of UK fertility clinicians, and 96% continue to offer IUI. And I think this totally makes sense because we are seeing all these studies that do show that there is an improvement in the pregnancy rates over trying naturally. And lots of patients aren't ready to make the leap into IVF, or they shouldn't necessarily be making the leap into IVF when they're younger, they have a good egg reserve, where taking the time to try a few IUI cycles is completely reasonable and could still very potentially work. And so although this is out there in one of the guidelines do not always agree. And again, clinicians don't always practice by the guidelines because we're the ones seeing patients in front of us. Guidelines are just that, just guidelines.
Let's talk about IVF versus expectant management for unexplained infertility. Just as a refresher, we cover IVF in episode 14 and 20 of the podcast. Everything that you need to know about IVF is in those 2 episodes. There was a study in 2004 that randomized couples into 2 groups. One group went immediately to IVF after the diagnosis of unexplained infertility, and another group had 3 months of trying on their own after they were diagnosed with unexplained infertility. The average age of people in this group was 33 years old, and the average duration of infertility in this group was 4.8 years. What the study found was a 50% pregnancy rate in the IVF group versus an 11% pregnancy rate in the expectant management group. Another review of the literature looking at multiple studies like this shows similar numbers with a live birth rate on IVF of 45% if you do IVF with unexplained infertility versus 3% with expectant management. So we see that the pregnancy rate is not zero with expectant management in the concept of unexplained infertility because this could still happen. People sometimes just have delay to pregnancy and things just happen at a slower rate, so to speak. But certainly there is a very clear, significant statistic difference between IVF versus expectant management in the concept of unexplained infertility, especially when you have a reasonable duration of infertility. In this particular study, we're talking 4.5 years.
Some studies have also looked at comparing IVF versus other treatments. Goldman et al. In 2014, they had the FORT-T trial where they had 154 couples with greater than 6 months of unexplained infertility in women aged 38 to 42. So they randomized these couples to 2 cycles of Clomid IUI or 2 cycles gonadotropin IUI or immediate IVF. And they found the live birth rate for Clomid IUI was about 8%. Gonadotropins and IUI was 7%. But the pregnancy rate for immediate IVF was much higher at 16%. There was another ESHRI multi-center trial published in 1991 that showed that the pregnancy rate per cycle with gonadotropins and intercourse was about 15%. Gonadotropin IUI was 27%. But again, with IVF was 25%. This will often depend on the dose of gonadotropins that are used, how many follicles are being created. IVF does lead to the highest pregnancy rates and highest live birth rates for couples with unexplained infertility. So even though we may not necessarily have a clear reason why the infertility is there, we know IVF is effective.
So not only does IVF in the context of unexplained infertility lead to a higher live birth rate, but it also is more cost effective. So the FAST trial that we were mentioning about before actually looked at this. As you might recall from the prior conversation, it had 2 arms. One is called the conventional arm, and these are people that had unexplained infertility, did 3 cycles of clomiphene citrate IUI, then 3 cycles of gonadotropin IUI, and then up to 6 cycles of IVF, versus the accelerated arm, where couples did 3 cycles of clomiphene IUI and then proceeded right into doing up to 6 cycles of IVF. And what the study noted was not only a higher pregnancy rate with IVF, but also a lower cost per delivery in the accelerated arm. These are the couples that did IUI 3 times and then went straight to do IVF. And the difference was $9,846. That's pretty significant.
Yeah, that's huge. Anytime there are trials evaluating how cost effective something is, it always really depends on the context. So, did the people in the study have insurance coverage or not? Did they have access to funding for one IVF cycle or no IVF cycles or multiple IVF cycles or not? This will absolutely change the numbers that we're talking about. So, we're not saying that because the study said that you're going to save $10,000, that you are going to save $10,000 as well, just because you skip over something, but you might. Now, to go back to the NICE guideline that was published in 2013, their conclusion or one of their statements is that they advise women with unexplained infertility who are having regular unprotected sexual intercourse to try to conceive for a total of 2 years. This can include up to 1 year before fertility investigations. And then they suggest going into IVF at that point, because we know that those pregnancy rates with IVF are much higher than with IUI or with timed intercourse.
In the context of IVF, another thing that comes up with unexplained infertility is whether or not ICSI or intracytoplasmic sperm injection is necessary or not. The studies and the guidelines would say that there is no advantage of doing ICSI over conventional fertilization in the context of unexplained infertility. I have to admit, I like to do a split of IVF and ICSI in unexplained infertility because there's nothing worse than having somebody that has been trying for 4 years. They do IVF, they get 15 eggs, the sperm is perfect. you do conventional IVF and lo and behold, you get no fertilization, or you get 1 out of 15 eggs fertilized. And then you go, well, that's why it was unexplained infertility. Now we understand that there was a fertilization problem, but we have no eggs or no embryos for you to actually achieve your goal. Because really, I'm more interested in the ultimate goal, which is a baby in your arms, than on making a diagnosis or being right about something or uncovering some secret about your reproductive potential. So even though the studies would suggest that X is not necessary, I do recommend doing a split because IVF is too costly of a test to just risk it and not have both method of fertilizations available to you.
Oh, absolutely. I think for when I'm seeing couples and they're doing their first cycle of IVF, like first cycle ever with unexplained infertility, my default is going to be to do half the eggs by IVF fertilization, half by ICSI fertilization. Even literally at the beginning of this episode, we said that one of the reasons why people can have unexplained infertility is fertilization failure. And you don't know that until you see the egg and the sperm together and see what happens. I can think of a couple that I saw early on in my career. The sperm was great. I was a young, bright-eyed, bushy-tailed fertility doctor wanting to listen to the guidelines, wanting to practice by the guidelines. And I did all IVF fertilization and they had nothing fertilized. And it was absolutely soul-crushing. I will never forget that couple and I'll never forget those patients. And even though I did everything quote unquote correct because I followed the guidelines and I was a good book smart, fertility doctor, these things are just that. They're just guidelines.
Now, is there anything else that we can do to treat unexplained infertility other than IUI and IVF? One may consider a diagnostic laparoscopy. There is a lot of controversy over this because the controversy is, well, even if you do have endometriosis, is that really the reason that you're having infertility or not? And we covered this in episode 8 with Dr. Zenny. But just to put it out there that if there are no other factors that can be identified, you do not want to do IVF or cannot do IVF for whatever reason, the possibility of having an assessment for endometriosis and a possible laparoscopy is something that can be considered in the right context.
Sometimes for patients who have unexplained infertility, and let's say we've done IVF and we've not been successful, then go on to sort of think, okay, maybe this is an egg quality issue or a fertilization issue, where maybe it's not so unexplained anymore. That's where we may think about things like donor gametes or gestational surrogacy. Those are things that are not necessarily for unexplained infertility. They're more for situations where, let's say we've done IVF and the IVF has failed for various reasons. And now we're thinking how to modify the parts of the IVF cycle to have a better outcome. This is, again, where that definition of unexplained infertility is really fuzzy. If you're thinking that somebody has poor egg quality or poor embryo development, you may start as unexplained infertility because you don't know that until you're actually doing IVF. And then suddenly the unexplained is maybe partially explained, let's say. And that's where this concept of a diagnosis and this concept of a label is really tricky.
So to summarize, we have said a lot of things and we hope that you're less confused than you were when you started. Unexplained infertility is frustrating because everybody wants to know. Everybody wants to go to the doctor and be told what's wrong and how we're going to fix it. And everything should be fit into a pretty little box. And no one, including physicians, like to talk about this could be this, it could be that. But, unfortunately, that is the reality of not just unexplained infertility, but many things in the world of fertility. We know that there is a diagnosis of unexplained infertility, which means normal ovulation, been trying for more than a year, open tubes, normal sperm. But we also know there's a lot of factors that can contribute to that, like age, possible lifestyle factors, possible weight, possible endometriosis, other medical conditions as well. We know that there is different treatment options. We can use IUI with medications or IUI with gonadotropins. We have heard in this episode that there is no evidence for using oral ovulation induction agents with time intercourse in the context of unexplained infertility. And we also learn about the benefit of IVF in the context of unexplained infertility in terms of a higher pregnancy rate and a lower long-term overall cost to treatment compared to doing multiple IUIs over time.
At the end of the day, we know that hearing you may have unexplained infertility is frustrating and can be demoralizing. And you may even lose a bit of confidence in us as your physician because we can't seem to figure out what's wrong. But I hope this episode provides a bit of clarity and explains our thought process when we're thinking about unexplained infertility and how the process of even making a diagnosis works in the world of fertility. The last thought that I want to leave you with, and I know Dr. Garcia will also agree, is that even if we can't figure out or pinpoint the exact reason why you're not getting pregnant, we have excellent fertility treatments and we have lots of options and things that we can do going forward to still help you get to that ultimate goal, to still get that baby in your arms. And even if we don't know the exact reason, fertility treatments, modifying lifestyle factors is still an extremely effective way to get to where you want to go. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.